Hi everyone. Good evening. I'm Dr. Prasad. I'm an academic head at Yashoda Hospitals, High-Tech City. So today, well, first of all, I welcome you all to the Friday webinar series of which we conduct every Friday for an emergency department. So today we bring you a very interesting topic and latest updates on very life-threatening condition called as pulmonary thromboembolism and the new guidelines. So although we all know that the prognosis is very poor and it requires a lot of clinical acumen to pick up the cases, because a lot of the times it's not so evident that you can diagnose pulmonary embolism. So to speak about the latest guidelines and how do you go about in patients with a clinical suspicion of pulmonary embolism, we have with us the eminent speaker, Dr. Sujender. He's a senior consultant at Yashoda Hospitals, Secunderabad. So he has a very rich clinical exposure. So over to you, Sujender.
Hi, good evening, everyone. Myself, Dr. Sujender, working as a senior consultant in the emergency medicine department in Yashoda, Secunderabad, as well as I'm an emergency and air ambulance physician as well. So today I welcome you all for this webinar to discuss about the latest guidelines on the management of pulmonary embolism, which are formulated by the American Heart Association and American College of Cardiology as well. So pulmonary embolism remains one of the most challenging as well as potentially life-threatening cardiovascular emergencies, which we encounter in the clinical practice in our day-to-day life, especially in the emergency department. Despite advances in the diagnostic imaging, the anticoagulation strategies, as well as the catheter-directed therapies and multidisciplinary response teams, the pulmonary embolism continues to carry a significant morbidity and mortality, particularly in the high-risk and intermediate-risk groups. So the newly updated American Heart Association and American College of Cardiology guidelines brings us certain important changes in the risk stratification models and role of the biomarkers and imaging as well. And the indications for the systemic thrombolysis, catheter-directed interventions, and pulmonary embolism response teams, which are the PERT teams, as well as the long-term anticoagulation and follow-up care. So these were the new important changes which are done in the new guidelines. And in the today's session, we'll aim to simplify all these updates and translate the evidence into the bedside practice and discuss how these recommendations impact the decision-making in emergency as well as critical care settings. So these are the first guidelines which are formed by the American College of Cardiology as well as American Heart Association and a group of emergency physicians and vascular surgeons. And this is all a multidisciplinary teams of 8 multidisciplinary teams. This is the first dedicated guideline which is formed for the pulmonary embolism. So initially in 2011 as well as in 2019, 2023, these were all the scientific statements which were done before, but there were no dedicated guidelines for the pulmonary embolism. So previously in the 2011, as we know all the guidelines, that the categorization was low risk, submassive, massive. So it was all a broad classification. But in the 2026, we have gotten 6 areas updated. The 6 areas which are updated are new clinical categorization system, which is very important for the ED physicians, and advanced therapy matrix, anticoagulation preferences, hemodynamic support sedation, and CTEPH versus CTEPD. It is chronic thromboembolism, pulmonary hypertension with chronic thromboembolism, pulmonary disease, and post-acute care. So we'll deep dive into the 6 categories, 6 areas which are updated. So this was formulated in 2011, where there was a submassive and massive category. So the disadvantage with that submassive category was it is a broad classification where most of the normotensive patients come under the submassive category. So in the 2026 paradigm aims to enhance the precision in severity classification and therapeutic decision making. So the key innovation is integration of the clinical and hemodynamic respiratory factors, where the R modifier is introduced into the 5-tier system. So as you can see, the 5-tier system here, A, B, C, D, E. This is the 5-tier system. Along with that, we have a respiratory modifier. So these were the previous classifications, as you can see, which are low risk PE, submassive PE, massive PE. The low risk PE, where you had the hemodynamically stable patients with no cardiac damage. And in the submassive PE, we have the normal blood pressure with the signs of heart strain, where the patient was hemodynamically stable, but there were the signs of RV dysfunction strain, right ventricular dysfunction strain. In the massive pulmonary embolism, where hemodynamic instability and patient was in the shock, systolic BP was less than 90. So this was the American Heart Association classification 2011, way back in 2011. Coming to 2019, and they have modified into a risk stratification where low risk, low clinical scores, and intermediate low risk, and intermediate high risk, and high risk. So now they have in the 2026, they have completely changed the clinical categorization, which is very easy to understand, very easy to categorize, especially for the ED physicians. Whenever you encounter, you need to have a high suspicion for pulmonary embolism. So we'll deep dive into each category. The class A is a subclinical, which is incidental and asymptomatic, where you find the pulmonary embolism, which is incidentally on a scan. So where the patient does not have any symptoms and patient is absolutely stable. Coming to class B, where the patient is symptomatic and has low severity index, low clinical severity index. And then further, we have different scores, which is PESI score, simplified PESI, and Hestia score. So we'll go deep into the different scores in the coming slides. Coming to the class C, where it is a symptomatic and elevated severity risk score, where you could see the PESI score is elevated and simplified PESI and Hestia, all the scores are elevated. So the patient is with the elevated clinical score comes under classical C. Class D, where patient is in incipient cardiopulmonary failure, which are the early signs of shock and normotensive patient. In the class E, where the cardiopulmonary failure with a cardiopulmonary collapse, and most of the patients are in the refractory cardiogenic shock and cardiac arrest. So coming into the categories, clinical categories, where, as I said, the category A is a subclinical, where the pulmonary embolism is found in the scan very incidentally, and patient is asymptomatic. So you can discharge the patient safely and you can follow the patient. Coming to the category B, the patient is symptomatic, where the patient would have some shortness of breath, hemoptysis, chest pain with symptoms and with a low clinical severity score. And it has further classified into B1 category and B2 category, where the B1 category, the subsegmental emboli can be seen, which can be a single or multiple. Thrombus can be seen, and the B2 is a non-subsegmental thrombus. So for the B category, the patient needs hospitalization for a few days and he can be discharged safely. Coming to the category C, where the patient is symptomatic with elevated clinical severity score. And it is further classified into category C1, category C2, C3 as well. So category C1 is normal right ventricular function with a normal biomarkers. So when you do the bedside 2D echo, you would see the normal right ventricular functioning. So there is no dysfunction. And the cardiac biomarkers like troponin and NT-proBNP are not elevated, which are normal. Coming to the category C2, where there is an abnormal RV, which is a right ventricular dysfunction, or an abnormal biomarker. Either of would be there in the category C2. Coming to category C3, where there are abnormal biomarkers as well, there's an abnormal RV dysfunction as well. If the patient is requiring oxygen support, at that category is called as a respiratory modifier. So for category C, D, and E, we have a respiratory modifier where we add the term R, which indicates saturation is less than 90 and respiratory rate is more than 30, and patient is requiring supplemental oxygen. So that's called as respiratory modifier, which is given to the category C, D, and E. So coming to the category D, where the patient lands in incipient cardiopulmonary failure, it is subdivided into category D1 and D2 as well, where D1, the patient still is in the transient hypotension. At this stage, The new guidelines has proposed us to give a fluid challenge. You can give a fluid challenge of 500 ml of normal saline, where the patient can come back to C3 as well. So all these stages are very dynamic. The patient from D1 can come to C3, patient from C3 can come to D2 also. So reassessment is very much important. As a ED physicians in the ED, reassessment is very important. So coming to the category D2, where the patient is in normotensive shock. So along with the normotensive shock, if the patient is requiring more than 6 liters of oxygen and requiring NRBM mass, then that's a respiratory modifier again. Coming to category 3, cardiopulmonary failure, and it is subdivided into category E1 and E2 as well. Recurrence persistent hypotension with a cardiogenic shock is E1 category. In E2 category, where the patient is in refractory shock or cardiac arrest. So this can be also added to the respiratory modifier, where patient is in the type 1 respiratory failure, hypoxemic failure. So in this way, we categorize the patients into A, B, C, and D. And this is a very crucial thing of categorization of these new guidelines. As ED physicians, we need to focus more on the clinical categorization. As we already discussed, the category A is subclinical PE, where you can discharge the patient to the home and there is no hospitalization required. And we would start the anticoagulation if there are no contraindications. So you can put the anticoagulation and discharge the patient home happily. So coming to the category B, already discussed as B1 subsegmental and B2 is non-subsegmental. Where you see the low clinical severity score, the PESI score is less than 85 and simplified PESI score is equal to 0 and HTR score is less than 1. PESI is the Pulmonary Embolism Severity Index. It's called as PESI, which is again modified as simplified PESI score. HTR score is a score to discharge the home. If you want to discharge any patient with pulmonary embolism, whether he's the right person to go home or not, that is decided by the HTR score. So if the HTR score is less than 1, then he comes under the category B, where he's in the low risk and symptomatic. In the category C, where you see the PESI score is more than 85 and simplified PESI is more than 1, and patient does not have any shock or hypotension. As we discussed, there is a stepladder form of C1, C2, C3, and patient will require hospitalization. He will require the ICU management. We'll be starting with low molecular weight heparin, and low molecular weight heparin is recommended over the unfractionated heparin for the initial parenteral therapy. We'll discuss more about the low molecular weight heparin and what are the advantages over the unfractionated heparin in pulmonary embolism. So coming to the RV dysfunction assessment in the bedside, as a ED physician, you need to look for the RV dysfunction on the 2D echo, where you measure the RV dimension, where the end diastolic diameter is more than 30 mm, and RV by LV ratio is more than 0.9, which is the end diastolic ratio, and the TAPC will be less than 1.6 centimeters. What is TAPC? So we measure the distance of systolic excursion of the RV at the annular segment on the M mode along a longitudinal plane from a standard apical 4-chamber view and from the end diastole to the end systole, and this is called as TAPC, and the TAPC should be less than 1.6 centimeters. And coming to the Doppler evidence of pulmonary hypertension, where pulmonary acceleration time we see, which is less than 90 milliseconds, and the gradient should be more than 30 mm of Hg. And tricuspid systolic velocity, where we see in the apical or a subcostal 4-chamber view, tricuspid systolic velocity should be more than 2.6 meters per second. So these are all for the RV dysfunction assessment, where we see use the bedside echo. So we categorize the patient into the category C. Coming to the category D, where the patient is in the normotensive shock in incipient cardiopulmonary failure, which is a pre-shock. So again, it is categorized to D1 and D2, as already discussed. In the D1, the systolic BP would be less than 90, and it responds to the volume expansion with a 500 ml to 1000 ml of normal saline with no signs of organ and hypoperfusion. In the D2, where the patient is normotensive shock, where the BP is normal, but lactates are elevated more than 2, patient would have the acute kidney injury or altered mental status, or cardiac index would be less than 2.2 liters per minute. So either of the end organ signs of hypoperfusion would be there. So this patient would require the ICU setting admission and or intermediate admission, where advanced therapies like thrombectomy, thrombolysis, systemic thrombolysis, which is considered the class 2B classification. Coming to the category 3, with the cardiopulmonary failure, which is subdivided into category E1 and E2. The category E1 is persistent hypotension with a cardiogenic shock, and E2 is a cardiac arrest and refractory cardiogenic shock. The management would be ICU and critical care, where immediate PERT activation team would be there. And we would further discuss about the PERT activation in the coming slides, where this patient of category would require systemic thrombolysis, surgical embolectomy, or ECMO as well, which is a class 2 indication. So coming to the respiratory modifier. So the respiratory modifier would, for the categories C, D, and E, the respiratory modifier is required for the patients who are in the category C, whose saturation is less than 88 to 90. Patient is in hypoxemia, type 1 respiratory failure with the tachypnea and requiring supplemental oxygen. For example, a patient with a breast cancer with sudden dyspnea, tachycardia, and hypoxemia with a bilateral lobar pulmonary embolism, but no RV enlargement is there, or there's no troponin elevated as well. So cardiac biomarkers are normal and RV functioning is normal, but patient is having type 1 respiratory failure. So we categorize as category C respiratory modifier. Coming to the respiratory modifier for category D, where the patient is requiring more than 6 liters, requiring a non-rebreather mask. Example of this, the patient would have the normal blood pressure, where there is an elevated lactates, there's an acute kidney injury and hypoxia requiring non-rebreathing mask. So there's an end organ hypoperfusion is there. In the respiratory modifier for the category 3, where patient might require a non-invasive ventilation or a positive pressure ventilation here. So patient would be in the refractory shock or a cardiac arrest as well. For example, if the patient has been admitted with a COVID-19 pneumonia and mechanical ventilation, who's been diagnosed with the saddle pulmonary embolism, severe RV hypokinesia on the echocardiogram, and patient is in the shock with hypotension with despite 3 vasopressors. So patient is in a refractory shock with a multiple vasopressor support. So this is categorized as a respiratory modifier for category 3. So coming to the scores used in the acute pulmonary embolism in the clinical category system. So in patients diagnosed with acute pulmonary embolism, according to American Heart Association and American Clinical Cardiology, category A and B, use of HESTIA, PESI, or simplified PESI risk scores is recommended to identify the patients with a low risk for short-term adverse outcomes. So this is a class 1 recommendation here. And the class 2 recommendation, where hemodynamically stable patients are diagnosed with acute PE with category C and D using a validated pulmonary embolism specific risk score, is reasonable to identify the patients with a higher risk for short-term adverse outcomes. Is a class 2A indication. Class 2B indication is in the hemodynamically stable patients diagnosed with acute PE, where category C and D, and then new score, which is a national early warning score, and its updated version is NEWS 2, may be reasonable alternatives to the pulmonary embolism specific risk score to identify the patients with the higher risks for short-term adverse outcomes who may require monitoring for clinical deterioration. So what is PESI score? So it's a pulmonary embolism severity index, where you see the how sick is the patient. As you see, the age plus years, the score is equal to age plus years plus sum of the risk factors. So what are the risk factors? If the altered mental status is there, patient would have a 60 points, and with a history of heart failure with 10 points, heart rate more than 110 beats per minute is at 20 points. Systolic BP less than 100 is 30 points. And chronic lung disease with 10 points. Respiratory rate more than 30 is 20 points. Saturation less than 90 is 20 points. So altogether, so we add up all the points. Score less than 65 or equal to 65 is class 1. Score 66 to 85 is class 2. 86 to 105 is class 3. 106 to 125 is class 4. More than 126 is class 5. So is the 5 classes which are the PESI score. So score is equal to age plus some of the risk factors. So to know the severity of the patient, we need the PESI score. So PESI is further modified and made very much simplified as simplified PESI, where we see the low risk or high risk. We have 6 items here, where the age more than 80, cancer is there or not, there is any chronic cardiopulmonary disease, heart rate more than 110 beats per minute, systolic BP less than 100, and saturation less than 90. So add any 1 point, patient would be in the high risk. If the score is 0, he would be in the low risk. Even for the 1 point, patient would be in the high risk. And the 30 days mortality would be 1%. So what is HTR score? So whether a patient can go home, whether you can discharge a patient. So it depends on these 11 questions. If the patient is hemodynamically unstable, if patient might require thrombolysis or embolectomy, patient is having active bleeding or high bleeding risk, more than 24 hours oxygen requirement is there, pulmonary embolism diagnosed while on anticoagulation, severe pain where patient is requiring IV meds for more than 24 hours here, medical and social reason to admit, creatinine clearance less than 30 ml per minute, and severe liver impairment is there. If patient is pregnant and history of HIT. So any one factor, if is a S, then that would require an hospital admission. As you can see, there's a decision switch. If any of these 11 questions, if any question got a tick mark, then patient require a hospital admission. That could be in a ward or that could be in an ICU setting. It depends on the severity of the patient. So coming back to the chronic pulmonary embolism score, which is CPES score, and this is for the normotensive patient who would go into the shock, whether he would go into the shock or not. So there are 6 items here. One is the elevated troponin level, heart rate more than 100. Patient would have a concomitant DVT, saddle PE, central thrombus would be there, RV dysfunction, which can be a moderate or a severe RV dysfunction, and elevated BNP. So each item has 1 point each, where 0 to 5 items, low risk for a normotensive patient. If patient has a 6 out of 6 items, then would be high risk for a normotensive shock. So this is a classification for a normotensive patient, whether he would go into the shock or not. So as we all know about the shock index, where we can calculate the shock index with the heart rate divided by the systolic BP, where the higher score, higher is the risk. And there is no cutoff point for pulmonary embolism as well. More the score, more the risk. So coming to the updated area 2, advanced therapy matrix, which are the categories based on that we decide the treatment. So the first category, what are the recommendations for the systemic thrombolysis? So class 2A indication where the patients with acute PE who are categorized in category E1 to E2 and acceptable bleeding risk in whom the advanced therapy is being considered, the systemic thrombolysis and anticoagulation is reasonable over anticoagulation alone to reduce the mortality. So we combine the anticoagulation with systemic thrombolysis in advanced therapy where for the E1 to E2 patients who have the accepting bleeding risk and who has a chance for recurrent PE. Class 2B indications where in patients with acute PE, categories D1 and D2, acceptable bleeding risk in whom the advanced therapy is being considered. Systemic thrombolysis and anticoagulation may be considered over anticoagulation to prevent further clinical deterioration. Class 2B indication for category C3, where the patient would require systemic thrombolysis and anticoagulation over anticoagulation alone to prevent further clinical deterioration. So class 2B indication wherein patients with acute PE treated with systemic thrombolysis and lower dose systemic thrombolytics may be considered to reduce the risk of bleeding as well. So when you see all these class 2A, 2B indications where the systemic thrombolysis along with anticoagulation, the patients with from C3, D1 to D2, E1 to E2 categories who can have the acceptable bleeding risk. The take-home point is systemic thrombolysis plus anticoagulation. Both together has a more effect than anticoagulation alone. So this is the take-home point for this systemic thrombolysis. Coming to the catheter-directed thrombolysis, in patients with acute PE, category E1, the catheter-directed thrombolysis plus anticoagulation is reasonable to prevent further clinical deterioration here and prevent the early mortality as well. Similarly, in the category D1 to D2 patients, the catheter-directed thrombolysis plus anticoagulation is very much effective and very much beneficial for them. Coming to the category C2, C3 as well, D1 to E1 as well, where the catheter-directed thrombolysis plus anticoagulation compared with the anticoagulation to prevent the short-term fatal and non-fatal clinical deterioration is there. Class 3, no benefit. In patients with acute PE, categories A1 to C1, CDL is not recommended. So patients who comes under class A, class B, and class C1, for them, the catheter-directed thrombolysis is not recommended over anticoagulation. So for them, anticoagulation alone can improve the symptoms. So from the class C2, C3, D1, D2, even the catheter-directed thrombolysis is indicated along with the anticoagulation. Coming to the mechanical thrombectomy, in patients with acute PE category E1, it is reasonable to choose mechanical thrombectomy plus anticoagulation over anticoagulation alone to prevent further clinical outcome. In a similar way, category D1 to D2, in whom the advanced therapy is being considered, and mechanical thrombectomy plus anticoagulation may be considered over anticoagulation. Category C2 with C3, the benefit of mechanical thrombectomy plus anticoagulation compared with anticoagulation alone is unclear, preventing the short-term fatal and non-fatal clinical deterioration. So in patients with acute PE who comes under category of A, B, and C1, mechanical thrombectomy is not recommended. So the take-home point is from C2, D1, D2, and even E2. Only these clinical categories we can choose the mechanical thrombectomy along with anticoagulation. So coming to the surgical embolectomy, class 2A indication where in patients with acute pulmonary embolism with category E1, surgical embolectomy compared with anticoagulation alone is reasonable to prevent further deterioration as well. In patients with acute PE categories D1 to D2, D1 to E1, and A2 to C3, all these patients we can advise surgical embolectomy with anticoagulation. So there is no benefit. Class 3, there is no benefit with from category A to C3. So category A, B1, B2, C1, C2, C3. These categories does not require surgical embolectomy over anticoagulation. So for them, anticoagulation is more beneficial when compared to the surgical embolectomy. In patients in category of E2, not a mechanical circulatory support or surgical embolectomy is not recommended. So patients who are in refractory shock as well as cardiac arrest, there is no benefit with the surgical embolectomy and mechanical circulatory support as well. So coming to the advanced management, a new specific recommendation for clot in transit, where there is evidence of free-floating clot in the right atrium or RV clot in transit, the utilization of advanced therapies over anticoagulation alone. As we discussed, surgical embolectomy, mechanical thrombectomy. So these are the advanced therapies along with anticoagulation is reasonable to reduce the risk of clinical deterioration. So as you can see, there is a thrombus in the right atrium there. So these are all the categories which we already discussed. So in the category A and B, we will start the direct oral anticoagulants, which DOAC, where we use the HTR score, PESI score, and simplified PESI score. So these are the tools to identify the suitability for outpatient treatment. So coming to the category C1 to E1, where we initiate the low molecular weight heparin. So C1 to E1, we initiate the low molecular weight heparin, and we measure the cardiac biomarker, measure the lactates, we evaluate the right ventricular size and function with echo as well, and use the validated risk score to identify the higher risk patient. We evaluate for a normotensive shock. In patients with the category E2, we initiate the low molecular weight heparin over the unfractionated heparin, and we initiate VA ECMO as well. So multidisciplinary PERT assessment team is required to guide the clinical management. From category D to E1 and E2, where we start the vasopressors on inotropic therapy. From category D1, D2, and E1, where the systemic thrombolysis is advised along with the anticoagulation and catheter-directed thrombolysis or mechanical thrombectomy as well. Coming to the updated area, which is the anticoagulation preferences. So why do we choose the low molecular weight heparin over the unfractionated heparin? So the class 1 indication in patients with acute PE who do not have absolute contraindication to anticoagulation therapy. The anticoagulation therapy should be initiated to reduce the risk of recurrent thromboembolism and death. Another class 1A indication with patients with acute PE with categories C1 to E1, they require the parenteral anticoagulation therapy initially, and the low molecular weight heparin is recommended over the unfractionated heparin to reduce the recurrent thromboembolism and major bleeding. In patients with acute PE who are eligible for oral anticoagulants, which are direct oral anticoagulants, are recommended over vitamin K antagonists, unless contraindicated to prevent the recurrent venous thromboembolism and reduce the major bleeding. So class 2A indication with suspected acute PA category C2 or higher category in whom the bleeding risk is low, it is beneficial to administer the therapeutic anticoagulation when imaging is delayed and not immediately accessible. So this is the anticoagulation therapy. So in the specific populations where you can see the patient with who are in pregnancy, those who have acute PE can receive anticoagulation with a low molecular weight heparin or unfractionated heparin are recommended to prevent the recurrent venous thromboembolism. Class 3 in patients who are pregnant and who have acute PE, direct oral anticoagulants and warfarins are potentially harmful and may result in miscarriages. So this is the point to be highlighted where the direct oral anticoagulants and warfarin are harmful and may result in miscarriages or fetal anomalies in pregnant patients. Class 1A indication, patients who are acute PE who are breastfeeding and require anticoagulation, low molecular weight heparin or unfractionated heparin or warfarin are recommended over the direct anticoagulants to prevent the potential bleeding in the infant. Class 2B indication, patients with primary or metastatic brain tumors and acute PE who are otherwise eligible for oral anticoagulation. DOAC may consider over the LMWH to reduce the risk of intracranial bleed. So these are the special patient populations for anticoagulation therapy. So coming to the updated area of CTEPD and CTEPH. So chronic pulmonary embolism with a pulmonary disease and chronic thromboembolism with a pulmonary hypertension. So patients who will be having the post-acute pulmonary embolism who carry the symptoms of pulmonary embolism even on starting with anticoagulation for 3 to 6 months. So these patients will be having the clots remnant in the pulmonary arteries. So that can lead to the chronic thromboembolism pulmonary disease. So they still have the clinical spectrum of pulmonary embolism and they have the residual pulmonary vascular obstruction. There's a group of people where there's a residual vascular obstruction without any symptoms. So people who have elevated pressure comes under CTEPH, which is chronic thromboembolism with pulmonary hypertension. And the people who are categorized where the pulmonary hypertension pressures are normal and there is no pulmonary hypertension, they are categorized under CTEPD, chronic thromboembolism, which is pulmonary disease. So this is again the symptomatic patients after acute pulmonary embolism, and how do you follow up the patient, where the patient comes after 3 months of anticoagulation after an acute PE. So there is a diagnostic evaluation is recommended to assess for a chronic thromboembolism pulmonary disease. So it is reasonable to obtain a transthoracic echocardiogram and a lung perfusion scan with a single photo emission spec scan, or with a spec with CT scan as well. For patients undergoing a diagnostic evaluation for CTEPD, a cardiopulmonary exercise, is reasonable to exclude a CTEPD. I think you all clarified with a CTEPD, which is a chronic thromboembolism with pulmonary disease. In patients with history of acute PE who have the resolution of symptoms and low suspicion for CTEPD, a follow-up CTP or lung perfusion scan is not beneficial. So those who have the symptoms even after the anticoagulation after 3 months, still they have the symptoms for the acute PE, are advised to go for a CTPA scan and lung perfusion scan. So persistent symptoms after acute PE. So class 1 indication, patients being evaluated for CTEPD who should have anticoagulation until the evaluation is completed to prevent the recurrent thromboembolism and CTEPD progression unless contraindicated due to high bleeding risk. Another class 1 indication where in whom the CTEPD has been excluded but have ongoing dyspnea and functional impairment despite more than 3 months of anticoagulation after an acute PE, a pulmonary rehabilitation program is reasonable to improve the symptoms and exercise. Another class 1 indication, patients with diagnosis of CTEPD with pulmonary hypertension, a referral to a center with expertise in managing CTEPD is recommended to optimize the evaluation and management. So class 2A indication with a diagnosis of CTEPD, but there is no pulmonary hypertension pressure elevated, a referral to a center with expertise can be beneficial in managing the CTEPD. So these are the patients for persistently symptomatic patients for after acute PE. And these are the recommendations for anticoagulation therapy by recurrence risk. So class 1 recommendation for acute PE and no major reversible risk factor, continuing anticoagulation beyond the initial treatment phase, that is 3 to 6 months into extended treatment phase, is beneficial to prevent the recurrent thromboembolism. Another class 1A recommendation, patients with acute PE due to major reversible risk factor, stopping anticoagulation at the end of the initial treatment phase, that is 3 to 6 months, is recommended over continuing anticoagulation into extended treatment phase in order to optimize the net clinical benefit of recurrent thromboembolism versus bleeding. In patients with the persistent risk factor, continuing anticoagulation at the initial phase into extended phase is reasonable in order to prevent the recurrent venous thromboembolism. So patients who have the persistent risk factor, even after the initial treatment phase of 3 to 6 months, the extended treatment phase is reasonable in order to prevent the recurrent thromboembolism. So class 2A recommendation is patients who have minor reversible risk factor, a shared decision making about stopping anticoagulation at the end of the 3 to 6 months of initial phase versus continuing anticoagulation into the extended phase to optimize the net clinical benefit of recurrent thromboembolism versus bleeding need to be done. As you can see, the risk factors of venous thromboembolism here. So these are the major risk factors: surgery with general anesthesia more than 30 minutes, hospitalization with acute illness more than 72 hours, with confined to the hospital bed where patient is admitted in the ICU, cesarean section, recent cesarean section with a lower limb fracture. And the minor risk factors would be surgery with anesthesia less than 30 minutes, out of hospital within 72 hours, or peripartum period, patients who are on estrogen therapy, trauma with a decreased mobility more than 72 hours, and hospitalization less than 72 hours. Persistent for risk factors with venous thromboembolism, patients who have active cancer or without ongoing treatment, or any autoimmune disease like rheumatoid arthritis, systemic lupus erythematosus, and inflammatory bowel disease, and chronic immobility as well. So these are the persistent risk factors for the venous thromboembolism here. And this is a beautiful picture which is showing the risk factors here. And these are the recommendations for the anticoagulation therapy for the recurrence risk. So you can go through with a class 1A recommendation. patients with the acute PE offered anticoagulation beyond the initial treatment phase, that is 3 to 6 months, into the extended treatment phase with a direct oral anticoagulation, unless contraindicated, is recommended over vitamin K antagonist to reduce the risk of bleeding. So DOAC is more preferred than vitamin K antagonist unless there is a contraindication. So patients with cancer who are offered anticoagulation beyond the initial treatment into the extended phase, either DOAC or LMWH is recommended over the vitamin K antagonist. Another class 1 recommendation, where the patients with cancer who are offered anticoagulation with initial phase extending into the extended phase, who have the contraindication to the direct oral anticoagulation, the vitamin K antagonists are recommended over the aspirin or no therapy to reduce the recurrent risk. So if there is a contraindication to the DOAC, then vitamin K antagonists are the recommended therapy. Class 2A recommendation, where patients who be offered anticoagulation beyond the initial treatment phase but have a contraindication for the anticoagulation, it is reasonable to choose the low dose aspirin therapy, where over no therapy to reduce the risk. If patient have the risk or refuse the anticoagulation, so the last resort is low dose aspirin over no therapy to reduce the risk of recurrent venous thromboembolism. So this is the anticoagulation therapy for the recurrence risk patients. So how do we follow? And this is a very big task for the pulmonologists and as well as the critical care specialists, where how do you follow up care for the acute PE? So class 1A recommendation, patients with acute PE, identify the risk factors through the history, physical examination, age appropriate cancer screening should be obtained to diagnose the undetected cancer. In the class 2B recommendation, patients with the risk factor for acute PE who have the family history of thrombosis or age less than 55 years, it might be reasonable to perform testing for a genetic and acquired thrombophilia if thrombophilia tests are anticipated to change the management. And class 3 no benefit in patients with acute PE, routine imaging with CT or positron tomography, which is PET-CT, is not recommended to diagnose an undetected cancer. So patients who are symptomatic with risk factors, and we need a follow-up of PET-CT, or we need a CTPA scan or a lung perfusion scan. So this is the follow-up care for an acute PE. So as you see here, there's a complex anticoagulation management and venous thromboembolism history or recurrent PE, unresolved symptoms here, where patient would have the dyspnea, exercise and intolerance. So those patients require a potential CTEPD evaluation, pregnancy-related PE, and complicated clinical presentations where patient present with cancer, severe chronic illness. So expert second opinion, seeking a second opinion on management of complex patient care. So specialty clinics are defined as those with expertise in pulmonary embolism management, such as pulmonology, critical care, hematology, and cardiology, vascular medicine, if available, a multidisciplinary PERT clinic. So this is the follow-up care for the acute PE. So everyone, we all have the doubt, how would be the patient activity and how can he travel after the acute pulmonary embolism. So class 2A recommendation is patients who are recovering from acute PE, it is reasonable to encourage the early ambulation rather than the bed rest to reduce the risk of complications. So patients with history of acute PE, use of compression stockings during the long haul, more than 5 hours of travel history, can be useful to lower the risk of DVT. So patients recovering from acute PE, categories C2 to E, it may be reasonable to restrict the long haul travels for 4 weeks after the initiation of treatment. So when symptoms have resolved, to reduce the risk of adverse events. Another class 2B recommendation, history of acute PE related to travel or immobility who are not currently receiving anticoagulation therapy. It may be reasonable to use one-time prophylactic dose of oral anticoagulant or parenteral LMWH on the day of long-haul travel to reduce the risk of recurrent venous thromboembolism. So these are the recommendations for travel and patient activity as well. So we have come to the end. I hope it's beneficial to everyone. So we have the 10 take-home messages here. So the first one is the clinical categorization with the categories 5, category A to E, subcategories ranging from low to high risk for adverse outcomes in order to enhance the precision of severity classification, prognosis assessment, and evidence-based therapeutic decision making for the patients presenting with acute PE. So, as a ED physician, it's very important to categorize from category A to category E. The second message is patients with acute PE who are asymptomatic with category A can be safely discharged from the emergency room and do not need to be hospitalized. Next is the patient can be discharged at an earliest with acute PE who are symptomatic but have a low risk of score, who comes under the category B, which are B1 and B2 category. Symptomatic patients with acute PE and elevated clinical severity score with elevated biomarkers, right ventricular dysfunction, incipient cardiopulmonary failure, and those with cardiopulmonary failure are categorized with persistent hypertension, should be hospitalized in the ICU care setting. Advanced therapies include systemic thrombolysis, catheter-based thrombolysis, mechanical thrombectomy, surgical embolectomy are reasonable for the patients with acute PE, category E1, and can be considered for patients with acute PE, category D1 and D2 as well. So these are the advanced therapies from D1, D2, and E1. These category patients require the advanced therapies. So this is the PERT team, where the pulmonary embolism response team is recommended to improve the timelines for the activation of from the start of the diagnosis of the pulmonary embolism. This is to improve the timelines of the care, where it improves the multidisciplinary team, involves a multidisciplinary team here. This is the PERT team you see here. And coming to the patients with acute PE who requires initial parenteral anticoagulation therapy, so low molecular weight heparin is recommended over unfractionated heparin here. In patients with acute PE who are eligible for the oral anticoagulation, so direct oral anticoagulation are recommended over vitamin K antagonists unless contraindicated to prevent the recurrent venous thromboembolism and reduce the major bleeding. Patients with acute PE without major reversible risk factor, in those with a persistent risk factor, continuing anticoagulation beyond the initial phase of 3 to 6 months into extended phase is recommended. So the last take-home point is patients who had an acute PE should be asked the PE-related symptoms like shortness of breath, limitation of activities, chest pain, hemoptysis. So the PE-related symptoms, they need to take the physical history as well as the clinical examination, and functional limitations should be done at every visit for at least a year to screen for the chronic thromboembolism, pulmonary disease, or other cause of dyspnea and functional limitations. I hope the new recommendations on the management of pulmonary embolism is beneficial for all the ED physicians here. And thank you for the opportunity. Thank you, Professor. Thank you, SEMI team. If anyone has questions, we can take over the questions.
Thank you, Dr. Sujender. It was a well coordinated session and it was very crisp. So basically, to sink in, it might take some time for you to adapt for all of us. And the categorization has previously we used to refer to mild, moderate, or we used to refer to as massive, submassive. So I think that terminology should be changed, and you should categorize or diagnose. You should put your provisional diagnosis into categories like pulmonary embolism with category so and so. That would help. And I think the echo was used as a diagnostic tool, but now it is only restricted to the RV assessment and the CT in regards to the CT report, although we don't report though. But in regards to CT reporting, they have asked, apart from the presence of clot in particular location, they were also asking about RV-LV ratio, and then they're looking beyond the location of the clot. So the reporting also, they have given certain guidelines on how to report the pulmonary embolism for a radiologist. So these are the things that that are slightly modified and that is particularly essential for an ER physician. See, the rest of the things are also good, nicely elaborated by Sujender sir. So, because patient, it is not necessary that patient should come to you at the first instance. So he can get a thrombolysis outside, or he might have received thrombolysis outside and come to you. So you should be able to identify those patients in which phase they are. For instance, someone who has used anticoagulation for 3 days now, sorry, for 3 months, and now he has come to you and you have done a scan or you have seen the patient subjectively, then such patient is not improving. You should know when to extend an anticoagulation, or patient comes in between after 1.5 month and he has some bleeding manifestations, then you should be in a position to counsel the patients about the risk and benefit of stopping the anticoagulation versus continuing the anticoagulation, because patient can come in any phase. So that's what the Dr. Sujender took us through, all the comprehensive approach. So ER physician should be braced up to all this and try to shift your. I know it's a little tricky for shifting paradigm shift, but I think we all have to move to the newer guidelines and newer terminologies. I hope this will be definitely useful. Thank you. And we don't have, I think we have one question. First line of treatment in a hemodynamically stable patient. So, hemodynamically stable patient, PE. Sujendra, you wanted to take it?
Yes. I mean, we need to categorize the patient first based on the clinical category. If you find it is an incidental finding, then the patient would be discharged home where the patient does not have any symptoms. But if patient is symptomatic, then we would start with the oral anticoagulation unless he would have any contraindications. That
So
comes
the
category B.
The hemodynamically stable patient can fall into any of those categories because especially with the category of D, he can fall into either normotensive or can have a hypotension. So you have to look into comprehensively the what is the patient status and then take an action. As Dr. Sujendra already has elaborated, the first choice would be 100% anticoagulation with or without additional supports. Additional support depends upon your subcategories, but anticoagulation remains to be same. If you are calling it as a PE, anticoagulation is the choice first, and then additive treatments are dependent on patient's category and clinical manifestations. And the second question that we have is DOACs preferred over long-term treatment. Yes, that's what we discussed just before. So DOACs are the treatment, and long-term treatment depends upon many things, persistent risk factors of the patient. For example, if patient is having a cancer, so it is not going to go away in 3 months. So it's going to remain with the patient for a long term. And then someone who is a pregnant lady. So in that, the risk factor remains the same. So you will have to continue the anticoagulation provided you will have to weigh between the risk factors and the bleeding risk, and then that determines your continuation of the treatment. And Sujendra, I think, would you able to take the third question? The pulmonary embolism causes cardiac arrest, initial rhythm, most common.
Pulmonary
They're
embolism.
asking if pulmonary embolism is causing cardiac arrest, what would be the initial most common rhythm?
Okay. So most likely that can be a ventricular fibrillation or a ventricular tachycardia, pulsus ventricular tachycardia can be there. But as we said, where it comes under clinical category E2, where there is a cardiopulmonary refractory cardiogenic shock or a cardiac arrest. In this stage, and there is no surgical embolectomy is not beneficial, as well as mechanical thrombectomy would not be any beneficial here. Only treatment would be the multiple vasopressors as well as inotropes here at this stage.
Yeah. I think let me pitch in one. So most common initial rhythm, according to the textbook and the guideline, they say PE is the most common, but it is not imperative that every patient who goes into cardiac arrest should have a pulseless electrical activity. So
Yes.
he can present with any of the rhythms, but most commonly, essentially, at least theoretically, it is PEA, pulseless electrical activity. And we have another question, pregnancy with suspected PE, preferred imaging. So when we have a pregnancy with suspected imaging, there are two lines of treatment here.
Yes.
So we used to, from the previous decades also, we have never asked for a
PA.
CTPA. We have
Never.
asked for VQ mismatch. So now VQ scan is also moved away from the planar VQ scan to scintigraphy. So I think VQ scintigraphy is the most preferred scan in pregnancy. Anything to add, Sujinda?
Yeah, that's correct. VQ scintigraphy. So this is the latest one for the pregnancy-related patients. And adding to the previous question, where the patients who are under category C, D, and E, so based on the severity, along with the anticoagulation, we add the surgical embolectomy or mechanical thrombectomy.
Yeah,
These
their
are the
question was
additive
what is the
advanced
initial rhythm?
therapies.
Their question is initial rhythm that we have answered one,
Yes.
and
Initial rhythm can be anything.
yes, and regarding preferred imaging we answered,
Yes.
and I wanted to say one thing. Yeah, the recent guidelines also says low radiation CTPA for pregnant ladies because they have
Yes.
found
No
that the
radiation.
radiation has a very minimal effect on uterus and the breast cancers and very less teratogenicities compared to the previous thoughts. But they're not recommending low dose CTPA. They still urge for VQ scintigraphy and duration of anticoagulation for a provoked PE. That's what. See, there is no fixed
There's no
duration for
fixed
the
timeline as
provoked
such.
or unprovoked. It's all tight. You have to start an anticoagulation, titrate according to the bleeding manifestations, and move on. Yeah. Anything to add, Sujendra?
We need to reassess the patient
Yeah.
timely and see the PE associated symptoms every 3 to 6 months. And we need to extend again the
Mm.
treatment based on the weighing the risk versus benefit. We need to extend the anticoagulation.
Yes. So basically, it's about the persistent risk
Yes.
factor or what
Persistent risk
kind of risk
factors.
factor is it causing PE. So even provoked also might have a temporary provoking and a permanent provoking also could be there. So depending upon that provoking factor, I think we should be able to titrate our
And
treatment.
we have the CTEPD clinics where they have the chronic pulmonary embolism rehabilitation program for the chronic patients who have the persistent risk factors. So that's what the recent clinics which have been, they need to categorize them with CTEPD clinics who are expert in the CTEPD, chronic thromboembolism with pulmonary disease.
So there is one more question which has popped up. So chronic complications of untreated PE.
Chronic complication.
So there is nothing like chronic complications of untreated PE. It depends upon the location of the
Yes.
thrombus and the
Size
symptoms of
of the
your
thrombus.
patient. So if it is involving the primary trunk, probably you should patient will obviously come to the hospital with clinical effects. If someone this I think this comes under a category of A category, incidental finding only,
Incidental
because
finding. Yes.
if the patient is not falling into A, if he falls into B or something, then probably we might think about starting an anticoagulation. But if the patient has a chronic PTE and he's asymptomatic, he falls under A category. So starting an anticoagulation would be there. If you're asking me about the complications of chronic PE untreated, it's very obvious that VQ mismatch will be there. So the patient can have a pulmonary hypertension secondary to right heart pressure, which is increasing. I think these are the two complications
That's correct.
that a patient can have. Or during any surgical procedures, during his lifetime, he has a segmental or subsegmental PTE. And if it goes unnoticed, probably they might look into it in a different context, incidentally, with different procedures. Anything else, Sujendra? Something
In
you want to say?
category B, where we have a segmental and subsegmental also. So these
Hmm.
patients can also present as a chronic pulmonary embolism. These patients may have
But
the low risk clinical score and they may present as stable only. They may be hemodynamically stable with
No,
anticoagulation.
the question is a chronic complication of untreated PE is what the question is.
Yes,
So
sir.
I think it all subjected to symptoms, and if there are no symptoms, PE is as good as it's not there. That's all. If you have symptoms only, you're going to investigate. If there doesn't have
that's
symptoms,
correct.
we are not going to investigate. And the silent complications would be something that we have discussed, like he can land into pulmonary hypertension, or somewhere in between the planned procedure, he can go unstable. The VQ mismatch would be there.
Yes, that's correct.
Or he can become a simple happy hypoxia patient, where he will not have symptoms. His body would have adopted to the
hypoxia.
VQ mismatch. Yeah.
Thank you for a great insight.
I think it's a great session. We have a good audience asking questions.
Yes.
So we hope we answered all your queries.
This is the first section I have seen so many audience with so many questions.
Yeah. See you all soon. And thank you, Sujender. It was a great day.
Thank you, Dr. Prasad, for your great insights into the pulmonary embolism. Thank you.